Right now, let us look into how to do ICL the correct way and toric ICL the correct way.
To do an ICL the correct way. After proper preoperative evaluation and counseling, the Vision ICL is implanted under topical anesthesia. The cartridge is filled with methyl cellulose and BSS from the tip to the base. Any air bubble is removed from the fluid. When the ICL is in sodium chloride V4, it is semi-hydrated and therefore takes 3 to 4 days after implantation to get fully hydrated. Due to this hydration, there are changes in the length and the optic size and the lens too, besides slight variation in power. Since Vision ICL V4C and V4B are the only model names come in BSS, it will have no change in diameter, optic size or power after implantation from what is labeled. The Vision ICL is withdrawn from the bottle with special applicator and lodged in the groove of the cartridge. The special ICL forceps is introduced from the tip and grasps the half-folded ICL at the base of the injector. It is gently pulled into the nozzle. The applicator is clipped into the injector. The base of the cartridge is inserted into the injector and locked in place. 2 side port openings are made and methyl cellulose is injected into the anterior chamber. The amount of methyl cellulose should be such that it should not overfill the anterior chamber. The stream of methyl cellulose should just merge with each other during the injection. The main port of 3.2 mm is made. The injector tip is placed in the tunnel and gradually the Vision ICL is injected into the AC. The 4 footlets are gently tucked under the iris. The pupil is constricted and the incision sites are hydrated. For the V4C Vision ICL, no peripheral iridectomy is required. The V4C will only be available for myopia with astigmatism correction. For everything else mentioned, the model is V4B, no central optic port. The reason is that there will be visual artifacts or disturbances if we put a central optic hole in plus lenses which have thicker optics. The perioptic ports are full length and 360 micron in each diameter. The ones on the foot plates are also full length but much smaller in size. The purpose is better fluid circulation around the crystalline lens and assist in visco removal. But these alone do not suffice the need not to have PIs. Therefore, PIs are required in a V4B model. During surgery, these ports can be utilized for faster visco removal by getting your IA probe near them. Please note the new toric markings on the lens body half extending into the optic region. Now, during patient follow-up, there is no need to dilate the eye to assess lens orientation in torics. Obviously, these lines are missing in spherical lenses. Do not expect the vault to change much from immediately post-op to any time later unless one has left a lot of visco beneath the lens. At follow-up, only in case of V4C, one might get a feeling on the slit lamp that the central optic port is slightly temporally shifted and therefore possibly a decentered lens. This is not true. Pupils are usually nasally decentered and therefore will give the impression that the port is more shifted to the other side. One would get this feeling very often. Please be mindful.
Thank you very much.